3 stable at this time. We've downgraded one to a lower level of care from critical. She is going to be transferred out of the ICU today and to the ward for the remainder of her hospitalization. The other 2 remain intubated, sedated. One has significant head injury, but clinically she is doing well. I think from a standpoint she's going to recover from this injury. She has many orthopedic injuries that need to be addressed yet, and will probably return to the operating room 1 or 2 more times to have those addressed. The final patient is in the OR this morning, undergoing orthopedic repair of some broken bones secondary to the gunshot wounds. She had a laparotomy done yesterday to look at the injuries in her abdomen and is doing well from that standpoint. Any questions at this time?
Are you releasing names of these patients?
We will not be releasing the names of these patients. We're going to leave that up, I think, either to the local police department or down in Roseburg.
What is it specifically that you offered up here? We were talking to the folks at the hospital at Mercy down there this morning, and they said they had to come up here because they needed neurosurgery, something, expertise that they couldn't offer down there. Is it safe to assume, or is it a fact that all 3 had head injuries? They were all had gunshot wounds to the head?
No, we had one with a gunshot wound to the head, one with a gunshot wound to the spine. I think, first of all, we need to talk about Mercy. They did a fantastic job yesterday in providing the initial care to these patients, triaging them. I don't know what they took care of down there personally. I haven't had a chance to talk with them, but the way they packaged the patients up and prepared them for transport and got them to us in a timely manner was fantastic. All the patients were hemodynamically stable and had appropriate interventions prior to being transferred to us. The most critical one was the one with the head injury. We knew they were coming. We actually activated our mass casualty protocols here at Sacred Heart Riverbend. With the number of potential injuries that we were expecting, I think I received the first phone call yesterday morning about 10:30. I was actually in the OR at that time, operating on another patient. Received a phone call from the trauma surgeon down at Mercy, who let me know the status and what to expect. At that point, we activated our trauma, our mass casualty protocols. We actually had 63 personnel in the ER by 11 o'clock. We needed 60. We activated 4 bays, 4 trauma teams, which consisted of an ER physician, a trauma surgeon, anesthesiologist, 2 nurses, a phlebotomist, a scribe, 2 med techs, a chaplain. And so it was a great response from the community. We had ER physicians, anesthesiologists, surgeons who were not even on call in or text in or even come in to see what we needed. We had two neurosurgeons, which we contacted personally, letting them know that we needed their assistance. We had 2 vascular surgeons come down to help out in case there were vascular injuries, and of course orthopedics. And then we had I think 8 trauma surgeons, general surgeons involved in the care yesterday.
How many hours do you think you spent in the operating room with these victims?
Dr. Littman took care of the one who received a gunshot wound to the chest and abdomen, and he can speak directly to how long he spent in that, and I'll just let him talk to that.
So in general, from the time that all of the patients arrived to the time that they got to the operating room is variable based on their injuries. For the 2 that were the most critical, they were out of the ER and into the operating room in 30 minutes or less, just depending on their injuries. The surgery that I was in took about 4 hours. The operating room was being utilized by one of the 3 patients for probably 6 or 7 hours total. But that was, again, spread out based on who needed to be in the OR at what point and how many surgeons ended up needing to be involved. In our operating room, we had 3 anesthesiologists helping get her ready for surgery, cardiothoracic surgeon evaluating the chest injury. At the end of the case, the orthopedic surgeon came in and evaluated the extremity injuries that needed to be evaluated. And so, I mean, it was a tremendous team effort as far as getting everything that we could get done at the same time. And, you know, making sure, of course, that she was still doing well under anesthesia and ready to continue doing well.
Were any of the patients alert and talking when they arrived?
Yes. The young woman that suffered the gunshot wound to the back was alert, oriented, and talking.
Was she giving any kind of information about where she felt pain, where she was shot, anything that helped you with her case?
Yes. Her physical exam, she cooperated with that, was able to participate and help us diagnose the extent of her injuries. It was a little more relaxed with her care because the injuries were not life-threatening. Of course, life, limb, and eyesight is how we triage patients with respect to who gets intervention first. Hers were not life-threatening. The bullet wound was low enough that she didn't have a lot of neurologic deficit. So we were able to take our time, get a computerized tomography scan of her back, assess where the bullet was, had neurosurgery come down, evaluate her, had the discussion about the benefit risk of an MRI, given the fact that the bullets today are all metal. We can't use an MRI any longer to assess that. He did a neurologic exam, made the determination that he felt that the bullet was impinging on the nerve and needed to be removed. Took her to the OR, I think probably 2 hours after she arrived, and took the bullet out. I was in the PACU, I think around 10 o'clock last night, and she was coming out of surgery at about that time also.
Did she say anything about the shooting?
I did not talk to her about that this morning. I purposely avoided that topic with her. I did ask her if she wanted to speak to a psychiatrist. We will consult psychiatry for all the patients once they're alert and oriented enough. I do know the nurse spoke with her and gave me some information about her mental status at this point. I can tell you that she has been affected greatly by this event in her life.
The patient that you say is still in critical and went to ICU, is that the person who was injured in the head?
There are two still in the ICU, and they're both still considered critical. The one with the gunshot wound in the head is the more critical of the two. But from a clinical standpoint, she looks very good this morning. Okay, we look at brain perfusion is what we're interested in because the more oxygen we get to the brain, the better off they are. She has good perfusion pressures to her brain this morning. They had to do a craniectomy to relieve the pressure on the head. She looks very good this morning. I'm optimistic she will, of course, have some deficit. What they will be, we don't know. Time will tell as we are able to wake her up, take her off the ventilator, get a better neurologic exam on her where she can participate. We'll have a better idea.
But again, all three expected to survive.
At this point, yes.
When you said some deficit, can you expand on that a little bit?
Based on site of injury, I mean, if you break down brain injury into blunt versus penetrating, the war data shows that penetrating injuries do better than blunt with their ability to return to the community, be fully functional. It's a left-sided brain injury, so she'll have either some motor or potentially maybe some expressive or receptive aphasia. In other words, she won't be able to speak or she won't be able to understand somebody talking to her. And we don't know. I mean, it's just that general area. She has, some benefit in that she's young. Young people do better than older people because they can remodel, recreate, or create new tracks of neurons.
How old is that patient? Like 18 or older?
I don't know. Yeah.
Both the young women?
Two are younger than the third. I don't know how old the third one is, but she's a little bit older.
Were you here 17 years ago?
No, I wasn't.
So none of you people up there were?
No.
Some of you look too young. Okay.
Well, what's it like? I mean, you guys see trauma all the time. You help people through these things. You're surgeons, you're in there in the OR. You know, to see these people coming from Roseburg, so many in Roseburg that were killed, injured. And what is it like for you guys? Do you have to turn a switch off in your brain in order to do the job?
Yeah. I mean, you basically, I get emotional when I first get the phone call. It bothers me, and then I have a job to do. You know, I get into a state where I don't think about the impact on the patient. I think about what are the injuries, what do I need to do. It's part of my training. I identify those things that are going to kill the patient in a quick manner. The number one cause of death from trauma is hemorrhage, and that's the first thing I'm concerned about. You know, number two is going to be central nervous system injury. What kind of injury do they have? What kind of injuries might they have to the central nervous system? We use the American College of Surgeons Advanced Trauma Life Support Protocols. Dr. Littman did a fellowship in trauma critical care. My experience is military. I had 4 deployments as a combat surgeon and one as a commander to Afghanistan and Iraq. Dr. Notenboom has trauma training in his residency. So it's part of what we do. You focus on the job. In these mass casualty situations, it bothers me when I get home. I mean, I've gone home and cried. It doesn't make sense to me. You know, I don't understand it. But hopefully, we're going to be there for these patients when it happens. It's going to happen again. It happened here 17 years ago. It's happened this year. It happens, in the U.S., So the medical community is there to help when this happens. And I think there's a lot of great learning has come out of the most recent war with respect to trauma care. The DoD has a great collaborative program with the American College of Surgeons and bringing all that data back to civilian care in the U.S. The state of Oregon has gone to establishing the level of care in this state to be that equal to what the American College of Surgeons expects. And they work in a collaborative manner between each of the areas in the state to help us communicate with each other and provide care in that first golden hour so that we can help our patients get to a surgeon and get the care that they need.
You talked about the victims being well cared for in transport. How were they transferred here, and how long did it take between the shooting and them arriving here?
Well, the shootings were around 10:30 in the morning. I think our first patient arrived around 1 o'clock.
A little before, I think.
Yeah. 2 of them came intubated and on a ventilator. Because of the risk of hypothermia in flight, because they came in a helicopter via life flight, transport time's about 20 minutes from Roseburg to here. They all get packaged up in kind of a cocoon type of wrap to keep their temperature high, keep all the heat that the body makes in, because it's very hard to keep the back of a helicopter warm. And even in the summer, you're at risk of hypothermia.
Did they go to Mercy and Roseburg first?
Yes.
Okay.
Yeah. Now, the one with the head injury spent very little time there, was then transported to us, I think, almost immediately after the injury was recognized. And I think Reach, was it Reach that brought him to us yesterday?
Both.
Reach and Life Flight brought the patients to us. And they do a fantastic job.
Any guess on how long they'll be here? All 3 of them? I know they're different conditions.
Well, when the patients ask me that question, I tell them I don't know. I don't get that crystal ball, but I tell them their discharge criteria. Okay, I suspect the one that's going to have, with the neurologic injury, the greatest neurologic injury will be with us the longest. We will be able to probably send her to a rehab center when she is, able to eat. We have good pain control oral agents, and she's had good return of bowel function. So once all those criteria are met, then we start talking. And all along the hospital stay, we look at the goals for discharge on a daily basis. We do trauma team rounds every week with social work, occupational therapy, physical therapy, nutritional medicine, and talk about the global picture of care for the patient. And where are they going to go? When are they going to go? Where's the best place for them to go? And of course, that we talk to the family about that also. I would suspect anywhere from, a week to 4 to 5 weeks, is the time span we're going to see. And it's going to vary from patient to patient.
Was there anything that was learned from this event that maybe was unexpected that you would want to share with, future hospitals if this sort of thing would happen? Is there something that is...
We always do debriefs. We'll do a hot wash here locally. We'll do a hot wash with Mercy through Dr. Littman in his role as the director with it's called the ATAB, it's the Area Trauma Advisory Board, which is part of how the state divides up trauma. There's 7 area trauma advisory boards. Dr. Littman chairs our ATAB, and he communicates with those that are around us. The ones to the south is ATAB 5, Area Trauma Advisory Board 5. And so we do hot washes. We talk about patient transfers, even when it's not a mass casualty, when they need to transfer a patient to us. There's a great collaborative effort between, our trauma team and Mercy's trauma team.
So there's information that will be passed on in the future?
Yes. Yeah. Part of trauma care is the PI process, the process improvement. We evaluate every patient. We look to where we did something that wasn't quite as good as we wanted it to be. And that's peer-reviewed and talked about amongst not only the trauma surgeons, but the ER physicians, the orthopedic surgeons, and neurosurgeons. And we do that on a monthly basis. These cases will be peer-reviewed. We will look at them critically to find out what could we have done better, what will we do better the next time.
We were told yesterday that there would be more than 3 victims coming here to Riverbend, and also included a male. Any word on what happened to those victims? Are they still on Roseburg? Or?
Well, the initial word we got was up to 7, then it was downgraded to 5. Then we were told that 1 died in the operating room, and the last one, they said they were going to keep down at Roseburg. So.
Any update on the hospital's blood supply, or are you guys still in good shape?
We're fine. Okay, thank you.
Thank you.